In the past half a century, the dietary calcium intake of rural, tribal, and urban India has really declined. Indians consume only 300 milligrams of calcium per day, in spite of India being the largest producer of milk as per recent meta-analysis published in Frontier of Endocrinology. Studies suggest that calcium deficiency is widespread among women in India. In fact, 46% Indian women consume less than 50% of calcium, indicating low calcium intake in the population. Calcium deficiency is impacting every stage of women's life, from pre-menarche to beyond menopause, and is becoming a very major concern in Indian women due to lack of awareness and modern lifestyle. So I actually want to appeal to all my colleagues to come together and observe August and September of this year as Calcium Awareness Month, and extend your support to this year's theme of calcium strengthening every stage of women's life. In this months, the next 2 months, we together will aim to do a lot of things, especially spread awareness on the role of calcium in every stage of women's life, screen every woman for the calcium intake in their diet, test bone mineral density of every woman, and initiate interventions to ensure calcium consumption by every woman in as per ICMR guidelines. Let us all drive the Calcium Awareness Month and strengthen every stage of women's life in this year of 2023.
I think, as a rule, FOGSI has always targeted girls and women. So adolescent is part of FOGSI's program, and we have always worked very hard so that this intergenerational effect can bring about the change. And calcium as a micronutrient is very, very important. In adolescence, especially the young girls, it has several benefits. We all know, as young mothers, we brought up children, strong bones, teeth, we know that. It also aids in proper muscle function, promoting healthy nerve transmission. These are some of the things which are not really known. And of course, it's a crucial mineral during the growth phase. And adolescent is a growth phase that we know. In fact, let's go on to the main important part of the function of the calcium, that is the osteoporosis and the bone health, which is really, really important. The significant improvement in the effects of calcium supplements is actually both on the bone mineral density as well as the bone mineral calcium. And especially important in the women is the femoral neck. As you grow older, you get femoral neck fractures. So this building up this femoral neck strength, or that actually tells us how strong our bones are. And of course, calcium supplementation can significantly boost peak bone content and can improve the bone mass. I think the whole health of the bone actually depends on the peak bone mass. And what we are working towards, we want a healthy generation, is that they start building their peak bone mass, because after the age of 35, this bone mass starts deteriorating. So I think preventive supplementation in young population is actually a shift in the window of intervention for osteoporosis. So it's something new. It's a good concept where we can target them really young so that we build up their bone mass, and especially young adulthood may be the best time to optimize the bone mass, especially the peak bone mass. As I've said before, calcium supplementation can significantly improve the bone mineral density and the bone mineral calcium, especially at the femoral neck. Moreover, supplementation in those people, who are at the plateau of their peak bone mass, it has a better effect. So at a certain age, the bone mass peaks, and that plateau is where you can, if it is low, people who have not been taking enough calcium, their diets are deficient, it's low. At that point, if you supplement, it really helps them build their bone mass, and that is really good. So in terms of bone health and the full life cycle of a person, the intervention window of calcium supplementation should actually be advanced to the age around the plateau of the of the peak bone mass, and that's actually between 20 and 35 years of age. And I think that is what we should target. And adolescent is when they're growing, they're building their body, and calcium supplementation is so important. So it has an effect which builds up. So maybe this window can be shifted. So I'm really a proponent where we should target our adolescents and make them healthy.
Preeclampsia in India is definitely there. It is not something like it is there in the other parts of the globe and not in the country. We do understand that the hypertensive disorders of pregnancy is one of the most interesting, intriguing, at the same time, very, very stressful aspects when you are managing a pregnant woman. Because we find that the effects of these hypertensive disorders of pregnancy can contribute to the maternal mortality and morbidity in women. We are very happy that in our country, we have been able to reduce the maternal mortality rate to the present two-digit 97 per 100,000 live births. But we need to understand that now when you look at the causes of maternal mortality, hypertensive disorders of pregnancy are contributing to a bigger chunk of maternal mortality in the country. And they are definitely on the rise. Now, probably it could be because of the lifestyle changes, or probably it could be because of the shift in the age of women opting to be pregnant. We find older women who are getting pregnant rather than previously some 3 to 4 decades back. It used to be mostly used to be women in the 20s, but we know the women in the 30s, late 30s and early 40s are becoming pregnant because of so many aspects, career, education, and so many other aspects. But these are also responsible for this rise in this NCDs, and hypertension is one of the problems. So when you look at the incidence of this HTP, it's about probably about 7% in the Indian population, and it varies definitely from different parts of the country. It can be anywhere between 5 to 15%. And when you look at eclampsia, which is a severe form of hypertensive disorder, where a woman gets this eclamptic fits, that is about 1.5%. So over the years, we have seen that the risk of eclampsia is there in different areas, ranging from 0.1% to about 5%, average being approximately 1.5%. And so many women, unfortunately, die with pregnancy-related complications. And we find that the hypertensive disorders of pregnancy are accounting for about a big chunk, almost 15 to 18% of the maternal mortality. Of course, we don't have well-established measures of predicting and preventing hypertensive disorders. Yes, there are some investigations now which can help us to predict the hypertension, but still we are trying to see how best we can improve this diagnosis and management of the hypertensive disorders. And what needs to be understood is that you need to identify the risk factor, and correct proper intervention at the earliest time in the pregnancy will definitely help us to manage these women better. And that will give better outcome, and we'll be able to save lives. We may be able to save the mothers from losing their lives or other morbidity. Even if we are able to save their life, we sometimes find the unfortunate situation, they go into those chronic hypertension. Some of the women have renal failures. All these aspects can be prevented if we intervene early and take care of the women. That's the importance of increasing the surveillance in the antenatal period and seeing that all women who are pregnant are given the antenatal support and access to medical services which can monitor them, and in case of necessity, they can be referred.
A very good evening to all of you. Indeed, a wonderful way to discuss a very, very important supplement which women should be having right from adolescent to menopause. And what I call womb to tomb, such supplements are needed for women. Even newborns would need calcium, multivitamins, things like that. Now, when we look at PCOS is not a single disease. It's like a metabolic syndrome. And this metabolic syndrome involves insulin resistance. The cells become resistant to insulin, so the cells don't function because they cannot utilize the glucose. And you get high glucose levels and you get high insulin levels. The ovaries don't function, small cysts which are arrested follicles and which look like PCOS. And the milieu of the ovary hole becomes androgenic and not estrogenic, which it should be normally. So that requires insulin sensitizers for these cells. And usually we give them metformin and all. But along with metformin, if we add calcium and vitamin D supplementation, we see that there is a great improvement in the PCOS related menstrual irregularities. The follicle maturation improves, the serum insulin levels improve, and the hemostasis model, what we call as the HOMA-IR, the hemostasis model of assessment of insulin resistance and the fasting blood sugar, and quickie, that is the quantitative insulin sensitivity check index, has shown the importance of these two supplements improving insulin sensitivity. Then the other thing which happens in PCOS is androgenic features like hirsutism. So hirsutism and the level of testosterone will decrease significantly if vitamin D and calcium are added to the metformin. And this has been shown in two or maybe I think 3 different studies, and has been a long experience of all of us also. Now, based on all these 2 trials, which are very prominent in the Internal Medicine Journal, co-supplementation with calcium, vitamin D also has a very significant improved effect on the cholesterol levels. So the serum triglyceride decrease, the VLDL decreases, the cholesterol levels will improve, and this improves the overall cholesterol. So complete treatment for PCOS is not a single drug. We need to address the metabolic syndrome as a whole. So with insulin sensitizers, especially metformin, supplementation with calcium and vitamin D are very, very important. Those are some of my thoughts of using calcium and vitamin D in PCOS girls and women.
I think, as Dr. Nandita mentioned, and as Dr. Malhotra mentioned, that in India, the problem of calcium deficiency starts from early in life and goes from womb to tomb. So Dr. Nandita stressed on the fact that a lot of adolescent women entered into reproductive age group without achieving the peak bone mass. And the result of that, we see also that Nandita mentioned that from the age 35, women are calcium deficient. So while in the Western world, the calcium requirements remain stable until menopause, in India, from our studies, we've seen that osteopenia, which is less calcium in the bone, starts from the age of 35. Now, the problem that happens is when menopause occurs, this accelerates. Soon after menopause, especially in the initial 5 years, there's a bone loss. And the bone loss happens to the extent of around 5% of peak bone mass is lost every year for the first 5 years. At the same time, as the age progresses, the calcium absorption decreases. And the calcium absorption in the reproductive age group is around 20 to 30%. But beyond the age of 45, 50, this efficiency declines slowly with age. So while Indian women require calcium probably all their life, after menopause, the requirement of calcium shoots up and there's a sharp increase because of the bone loss that happens due to menopause and also the decreased absorption that happens with age. In fact, by age 65, the efficiency of a woman to absorb calcium is approximately half of that of what it used to be when she was an adolescent. And that is why we need to concentrate on increasing the calcium supplementation after menopause. I think Indian women, given their situation, especially from the age of 35, they need calcium supplementation, but they need a dosage of 500 milligrams per day would be enough. There are 2 times when this needs to be increased. One is pregnancy and one is menopause. Once somebody goes through menopause, their requirement of calcium would go up to approximately 1500 to 2000 milligram per day if they're not taking a hormone therapy. Now, if you give them an estrogen therapy, then what happens is estrogen decreases the amount of bone loss. So you require a little less of calcium. But these days, we do not give estrogen purely to prevent the bone loss. We give it if somebody is getting symptoms, menopausal symptoms and otherwise. Then their requirement of calcium would be, along with estrogen, would be around 500 milligram to 1000. But ideally, if they're not taking estrogen, the requirement would vary somewhere between 1500 to 2000 milligram. And that's a lot of calcium. And as I said, while we see in Western world, women start losing their bone mass from the time of menopause, in India, there are studies which have shown that they start decreasing their bone mass even from the age of 35 years. And that is why the necessity to have a calcium supplementation till menopause and tripling the dose once they get into menopause.
That in PCOS, you have insulin resistance. Insulin resistance means the cell is not going to let the insulin work so to utilize the glucose which we eat. And these cells happen to be in the ovary. And if those ovarian cells don't work, the cumulus cells and the granulose and the theca cells, the estrogen will not be produced. And the whole milieu, the conversion will, rather than estrogen, there'll be a lot of androgen, male hormone inside it. So to improve the insulin sensitivity, we give insulin sensitizers. It could be metformin, myoinositol, dichloroanisole combination. But if you don't add calcium or vitamin D to it, the effect is much lesser. So if you want good effect of the insulin sensitization of metformin hormones like that, or drugs on PCOS, we add calcium and vitamin D3. And as it is, everyone has said, Indian women are very vitamin deficiency, women, men also, and of calcium deficiency. So we need to take vitamin D3, and that is what is slowing down our lives. And menopause comes early to Indian women, as it has been said, so it has to be carried on. Otherwise, they'll fracture their bones, hips, and most old grandmothers have died because of hip fractures and being bedridden. So we need to prevent that.
With oral contraceptive pills, it depends on what kind of pills they're taking. If it is an estrogen progesterone combination, then that's not much of a problem with the bone. But if it is only on a progesterone only contraception, be it oral or be it injectable, then there is some amount of bone loss. Especially with injectable, there is a significant amount of bone loss. And that's why it should be avoided in adolescents and also in perimenopausal women. But even with progesterone only pill, there is a problem with bone loss. Whenever there's an estrogen progesterone combination, usually there's no significant effect, especially on short term.
Patients who have repeated pregnancies, patients who are already lower on calcium diet, calcium deficiency, patients with twin pregnancy, and patients with bad obstetric history, they are losing, and patients with already deficient in calcium or they are on some drugs before pregnancy, like GnRH and all. So they already enter pregnancy in deficient state, in pregnancy deficiency in the diet, or multiple pregnancy or quick succession pregnancies. It's very, very common, even more common in educated people, and so many days of their life gets lost because they say in premenstrual phase they are not able to carry out with their routine and all their mental health gets affected. It's very common. Actually, on milder degree, it is very, very common, and even severe degree patients where it is incapacitating their day-to-day life, it is common.
When we ask the girls, school-going girls or young women, almost 60-70% will say they have PMS, and severe PMS 20-30%. Dr. Alka is very, very common. But if you don't ask, and if those girls tell their mother, I'm having menstrual pain, arey ye to sabko hota hai. So that is the problem, it is ignored. And it is
Awareness is not there.
so aware. So the people hide it.
They don't even know they are suffering from PMS.
So that is the problem in India, because they don't come out and tell. And if they don't come out and tell, how can we treat it? There are going to be drugs which will induce deficiency because they they interfere with absorption, they interfere with utilization. There are drugs, anti-cancer drugs, there are neuro drugs, there are antidepressants. All these drugs, when you take not only calcium, they'll cause a deficiency of all the multivitamins and all. So with most of these, even some antibiotics and all, and if it is calcium is not taken properly at the proper time, that also. So we need to be aware of which drug is going to cause interference with the absorption of which supplement, and either we separate them, giving them, or make a time difference on when we give this drug, or give something extra, or give an extra vitamin D and calcium combination. So yes, the doctors have to be aware and of this and take care that drug-induced deficiencies don't occur.
Since times immemorial, all our senior leaders will remember that for many, many decades, we've been battling with two major issues with respect to the safe delivery care in our country. One was blood loss, that is in terms of complications of PPH, and the other is hypertension or high blood pressure with the preeclampsia. So why is it that the incidence is so very high of preeclampsia in our country? So when this came up again and again, is it the Asian ethnicity which is the root cause? Why the Western world is not having such a huge number, and why are our women dying of complications of eclampsia? So when that was discussed in the ministry, there was an issue discussed about the role of the nutrition or the vitamin deficiency, particularly the calcium deficiency, because maybe that our population is something to do with allied nutritional deficiencies, which may enhance so many of the problem processes in women's health, inclusive of preeclampsia. So that time there was a debate that government is supplying the iron folic acid tablets for control of anemia. Why are they not supplying the calcium tablets? Because the huge population needs this, and it's not only for deficiencies, but it has other benefits also. Then the question to the experts was, what other benefits does it have? We said, yes, if it's given in a higher dose, it prevents two things. One is preterm labor, one is preeclampsia. Because we're hugely deficient, and both these, preterm labor with tiny babies, in the neonatal intensive care, loss of life, and the mortality is one huge vertical chunk of an economic burden, whereas the other extreme is the mother may not be alive to see the next, what is happening to her family, that is the preeclampsia, eclampsia, and its complications. So when this discussion came, Dhwani, they said, do you know how much calcium an Indian woman is eating in her diet? Then let's plug the remaining deficiencies. Then there was no data about how much calcium an Indian woman is eating. They said right across the country, we don't have any documented data of the amount of calcium in her daily diet. Narendra said milk. Yes. How much milk? 4 glasses. Does she have 1 glass or does she have 4 glasses? Does she have buttermilk? Does she have curd? Does she have ragi and such millets? No clue, no idea as to what the deficiency is. Then they said, first you find out how much deficiency, then we will supplement the calcium. They said, then the UNICEF said it will take 2 years to find out because the situation is so bad. We said, okay, guys, presume that she's having 1/4 of the calcium from the diet with whatever she's required. Let's support with the routine supplements of calcium in every pregnant woman. That's how the deficiency status started getting plugged in. But those, with predictable eclampsia, preeclampsia, now we have ways of predicting this if the right kind of tests are done at the 12th week of her pregnancy. This is in the FIGO guidelines. FIGO is our international organization. It's properly put down in the guidelines. One is you take a lot of points to the history. Then you take the blood pressure in both the arms and calculate the average. third is you do some blood test, and the fourth is you do the scan. With all these 4 parameters, out of 10, these 2 women are prone to preeclampsia, is what you can find out. At least in those, yes, it is usual to give the aspirin supplementation, 150, but also plug in with a higher dose of calcium, because there is a good enough literature support for enhancing the dose of calcium, which is also a preventive care for preeclampsia. If we really pay attention to this, because nutrition in our head and on our pens, it has not come as a convincing prescription to our patient. We know it's important generally, and we are so general about it. So it doesn't help, because, the casual way in which say, "Ha, acha khana kha lo," that doesn't help. We have to bring it to their notice that this is a simple thing to do, but it has huge benefits in terms of plugging in the morbidity and mortality issues. So this is the calcium story, where we know our women are deficient. Some studies have been done in very affluent countries. There they have shown, no, supplementing calcium does not make any difference, because their women are not deficient in calcium, right? So that is the difference. So we needed the Indian data, which we now have, and South Asian data, which is also supporting the same, and the developing country data. Huge document on nutrition is released just last week, because September 1st to 30th, the entire month is declared as a Poshan Mahe, or the nutrition month in the country, because we want to make noise about it. We want to tell people, if you're eating right and investing in preventive care and wellness, it will go a long way. So that is about how the calcium has now occupied the center stage, not only to plug in the deficiency for a variety of problems with other experts who have discussed about bone strength and beyond, but also dreaded complications like preeclampsia and preterm labor, which will go a long way with just the supplement that she has to take. And I think, unlike some other preparation which cause a lot of gastritis and stomach irritation, this, that, and other side effects, calcium is quite easy on the system. And if you convince them that they need to take it, I think women will take. They have already started paying attention to a lot of these wellness issues. And I do hope that in the near future, the journey towards wellness, supported by, discussions like these, with nutrition as the center stage and lifestyle changes which are inculcated into their minds, will go a long way in seeing a healthy generation next. A lot of, again, the specific research and data is lacking. Calcium we've already outlined, but magnesium also is supposed to be one of the key ingredients which will decrease the chances of diabetes in pregnancy. So that's a new emerging role for magnesium that is coming in, because again, beyond the blood pressure and the bleeding after birth, another main concern in pregnancy is the tsunami of the diabetes in pregnancy. So the micronutrient supplementation, which WHO is now recommending, includes some magnesium, and it is for strong reasons such as preventive care for diabetes. You're way too late, because the way this whole calcium functions in our system is up to the age of 20 or 25 years, that is your calcium bank deposit. Okay, like what calcium you build up and store in your system, that is your peak calcium bone mass, which stays with you. Then as you get into the reproductive age, one pregnancy after another pregnancy, there is a loss of calcium. By aging also, there is a decline. And perimenopausal, postmenopausal, this is your bank balance. Yes, it is declining. As you get into postmenopausal, you're supplementing calcium, maintaining this balance, you're there. But if this is your bank balance, it is also declining. How much ever calcium you give, you cannot rise up. You can just maintain what little you have. So that is the concept behind early to awaken regarding the issue of calcium deficiency, especially in the adolescent, teenagers, pre-pregnancy, And by then, they must actually store enough calcium, because like a, like a coin which just erodes in course of time. So the calcium from your system will erode. So what builds the bone is continual exercises. That's why we tell the lifestyle changes, because it remolds and rebuilds the bones. Calcium supplements you will take so that you don't further deteriorate and you just maintain the balance. Some other, supplements like bisphosphonates, etc. And the hormone replacement therapy, which is also emerging as a frontliner, as our understandings are getting better and better. So it's a comprehensive kind of a care that you would offer to this age group. But for anything to work well, premenopause and perimenopause and into the menopausal age, you must act today for a better tomorrow. Thank you very much. Namaste.